Dr. Suresh, sir, we are live now, sir.
Welcome to the module number 14, which is going to talk about the black box versus explainable AI. So most of us are still not clear whether the AI is telling something right or wrong. So to take us through, we have Dr. Srikanth Sampara. Over to you. And please, the rest of the people keep themselves on mute, sir. Thank you.
Okay. Uh, is that green for me to start? Are all connected live?
Yes, sir.
Okay.
Please start, sir. Dr. Srikanth.
Okay. Uh, Gentlemen and ladies, the question is today the most important point about what we are about to discuss is not whether AI is relevant in today's context or AI is not relevant, it's not for me or something. It has already come into our lives. And what we are trying to cover in this session would be a responsible use of AI and what are the different things that you'll encounter when someone gives you a AI solution or AI model. And I'll cover these terminologies as we move forward. The point is, it's not about option anymore. It's more about whether the decision you're taking based on an AI output is able to trace back to the source. Is it auditable, and can it be defended both to patients and their families as well as medical legal circumstances? So without much ado, I will just start the presentation. And the first thing is disclaimers. I don't want to spend, but something that we need to understand is regulatory approval, whether it is software as a medical device or CDSCO, FDA guidelines. These are not ceilings. They are the floor on which we stand, and they should be the basis foundation for us before we take any decision. Just going back into the past, in 2013-14, I met a eminent doctor who said you can go and buy a treadmill machine in any sports shop and it has no impact on medical fraternity. But the moment you use that treadmill for the treadmill test or TMT, then it requires regulatory approval. The point is in 2022, 23, 24, software as a medical device has come up strongly where people are saying these things have to be taken into cognizance. The reason is any model built on historical data will drift. There will be data drift, there will be model drift, and there will be errors. So these are the responsibility of a physician who's using that for clinical decision making. And all AI predictions or all AI classification models are only probabilistic in nature. They will not give you definitive diagnosis. And of course, you will come across a lot of models that are deployed online. However, those are on Western population where their demographics are very different, their physiology is different, their genetic makeup is different. Are they tuned to South Asian population, specifically Indian population, and even more specifically your population? So we will cover this in next few slides. By the end of this session, you should be able to, the moment you see a model, in 30 seconds, you should be able to determine what kind of a model is it and can I base my decision on that. And that being the objective, let me just move slowly to the next slide. Today, AI is a reality. The 3 a.m. or 4 a.m. fatigue a clinician or a radiologist face is not something that an AI faces. It can process millions of images or lab reports or something. And by the time you wake up, it's all sorted out. Your patients are sorted out, your images are sorted out, and the terminology that I put in the agenda, glass box, black box, explainable AI, though they look slightly obvious, but we will go into deep in saying what are these, basic thing. What is it? When to use it? Why to use it? How to use it? These are the four fundamental questions this session will address. Um, and then we will look at some real successes and failures in AI in the healthcare industry, and then key takeaways, actionable principles to remember in your clinical practice. That said, you already use AI every morning, even before you pick up your first cup of tea or coffee. Your email has spam filtering, which is an AI classification model. Patient triage, like I mentioned like a second earlier, it will sort out the patients which need your attention the moment you hit the hospital. Radiology pre-screening. The bottom line is in 1980s, a clinician or a doctor had to deal with 100 data points per patient. Today, it has gone to 100,000 plus. So AI with such large volume processing capacity is a necessity in today's world, especially in places where the clinician and patient ratios are skewed. Radiologist and the lab test ratios are extremely skewed. South Asian countries, India specifically. In one recent survey, I came across a statistic that says 1 is to 10,000 is the ratio of a radiologist to the number of scans he should see. Yes, human error is bound to creep in. As a clinician using something for clinical decision making, what should you be aware of is the fundamental and big question. Like I said, AI is here to stay. It will not replace, but how can we use it wisely, safely, and along with the guidelines? Because taking a decision and telling someone AI said so, so I took this decision will not hold anywhere. Not with patients, not with colleagues, not with medical legal community. It has to be used for faster, better care. And in sometimes it also has a side advantage of being predictive in nature. Preventive in nature. So the point is, it is here to stay. It is how we adopt to this technology. 20, 30 years back, mobile phones were not there. At least I was there in that era where we were using landlines. Today, mobile became our everyday thing in everyone's hand. So it is here to stay. How do we use it responsibly? Now, this is the fundamental question that I ask everybody, and since I'm addressing a large audience, I want to emphasize on this. How many of you think AI is a revolution that happened in 2021 with frontier models like ChatGPT or Claude or Perplexity coming into the play? And how many of you think is a evolution that happened? The question is, in 1950s, Alan Turing asked, can machines think? That started the question. And Turing test is supposed to be the foundational basis for anything. What is Turing's test and all, I'll answer in Q&A. But in 1954-56, both the years put together, in Dartmouth conference, John McCarthy coined AI as a name. Then the big thing started. There was an overhype. Governments put in billions of dollars into AI, thinking all machines can think, they can replicate human reasoning and logic and all. But AI failed in its expectation. There was too much of a bias. So the AI winter, all funding was withdrawn, AI was pushed to the back burner. The breakthrough happened in Deep Blue when it beat the world chess grandmaster Kasparov, and then the neural networks re-emerged. that same neural networks are working in the LLMs that we use daily. It is exactly the same, but they're trained on large corpora of text that is available on internet that makes ChatGPT make you feel comfortable or Claude to make feel comfortable in mimicking human reasoning and logic. Okay. Now, before I jump into the types of models and how you take a decision and all, I thought I'll just pause, take a step back. I know this is module 14. You have been exposed to the whole lot of discussion around AI, but what is fundamentally a model? When we say model throughout our AI language or terminology, it's nothing but a mathematical function which takes all the input data, learns on the input data, and gives you actionable outputs. There are three different models. One is predictive, where there is an example. An algorithm analyzes vitals in real time and predicts sepsis onsets before 6 hours before clinical symptoms appear. That means a life-saving predictive model. The second example is classification. It doesn't do anything. It looks at mammogram data in anything and classifies an abnormality as benign or malignant. And then there are descriptive models which are useful in medical context. Um, to see the best example I can give you is, can you cluster a group of patients who are into what you call type 2 diabetic patients, or readmission is a big example. How many can you predict that these guys are getting discharged and they will get readmitted in next 30 days, and why? The most important question is why. So that is descriptive models. Can I minimize the video screen? I think the audience will not be able to see the text on the slides.
They are able to see, sir. Don't worry. Please continue.
Okay. Okay. So descriptive models identify the underlying structures or patterns, and they answer why a particular thing, and they use that to give insights into a certain behavior or a certain set of people. So these three are models. Now the rest of the session will continue, assuming that you already have an AI team or AI vendor who has given one of these models in your hand and it is doing its job. How can you make a clinical decision making on that, or clinical decision on that? So that's an important question. So the rest of the session will focus on that. I'm consciously pausing and going slow on this one, but however, the three of these models are the models that will come. Uh, Driving a car, you have two choices: either learn how to drive a car, or you get into the underneath of how engine, transmission, brakes, and everything works. This session will be focused on, you already have a car and you're learning how to drive it properly. And in this case, the car being AI. So, like I just mentioned, it learns, it maps inputs, whether it is lab notes or images or and it predicts, right? But the most important thing that you need to understand is probabilities. They are not certainties. And that probability is always given in percentages, in accuracy measures, and all that stuff. The fundamental ground rule that we all live with are correlations are not causations. The thing is, any correlation need not necessarily be, if A and B are highly correlated, doesn't mean A causes B or B causes A. It is your responsibility as a clinician to add the medical context before you take the decision. Let's just take a quick look into the three types. The names are self-explanatory, like I mentioned in the beginning. Glass box, like for example, MELD score or something that you have been using from last 15, 20 years. Every decision is completely transparent. You see every feature or variable and its weight, and you can verify it against your medical knowledge. The thing is, these are glass box models. They stand audit scrutiny. It's easy to explain to patients. It is medico legally accurate, and these are all validated across the globe. Now, there are certain, in this session, the most important thing is one type of a model is not either better or inferior to another type of model. What is important is how you use it and in which context you apply and how to get the best out of it. That's the fundamental thing. Now, the black box is an interesting case. It deals with large volumes of data, like 100 million plus parameters in deep neural networks. I'll show you a live example of how it works. Uh, and it can handle large number of variables. And some of these patterns humans will miss, not may miss or humans miss. They will miss because it is humanly impossible to process that volume of data that is there in the clinical context or a medical context. But it can identify precisely where there is a hemorrhage in a CT image. Now, that insight, 1 hour or 2 hours before, can actually save a brain tissue. Now, the most popular example that we keep coming across in this is retinopathy screening. It is an extremely narrow task. It does screening on images, and it says refer, do not refer. And it is highly applicable in low represented areas like rural settings and where there is extremely skewed population towards practiced ophthalmologists versus the patients. And the moment it says refer, they are sent to an institute for referring. So this is where, and we'll come across this point again and again in the presentation, where black box becomes very relevant. It doesn't explain, it's opaque to you. You don't know why it said refer or do not refer. Now, so I am pausing on this slide so you can have a quick look at this slides on why, when to use it and examples. Those examples are obviously not very exhaustive. They're condensed to for the slide where. The second one is explainable AI. So we have seen glass boxes, which are standard formulas that can be traced back and used. Black box. Explainable AI rides on top of a black box. It gives you insight into why a black box is predicting something. So those SHAP, shapely additive explanations, they are all technical terms. Like I said, I don't want to reverse engineer and explain the technicalities behind that. But like if you see on the right hand side, there is this mammogram data, where the AI has highlighted a particular region which is a anomaly or abnormality in a simple language. Now, the question is, a radiologist can quickly narrow down onto that and investigate that. So what happens is AI brings the attention to that region, and the radiologist or a clinician will decide whether that warrants further investigation or not. So that is, in essence, a explainable AI. through visualizations, so there are 10,000 variables or features meaning age, gender, location, habits, lifestyle, past electronic health record. All these things will go in as features, and it will give you top three, top five reasons why it has given you certain prediction. So again, it's uh, please remember all these techniques that I mentioned on the slide are approximations. You have to apply clinical judgment or clinical decision making before you go to the next stage. Right. The workflow is very clear, very simple and clean. Patient data goes in, there's a black box AI, and then the interpretation layer, visualization layer, and the doctor verifies and says, yes, this warrants further investigation or further tests. Now, till now, just let me go slow down a little bit and recap. So we have seen what a model can be or will be. Then we have seen glass box models like MELD and CAD and things like that. And both of them, glass box as well as explainable AI, are auditable. They can trace back to the source data and explain this is the particular reason why I am giving. And black box, where to use black box? You will use black box when the task is extremely narrow and the output can be used confidently. Now, the risk of these things is when AI makes a mistake, the mistake is silently made. You will never know because the output comes so convincingly that you will never know that there has been a mistake. You have to build these guardrails around the model. So when a vendor comes and says, I have a ready-made model for predicting MI. So here I will just pause and give an example. You're a doctor who has seen 10,000 cases you're a cardiologist, you have seen 10,000 cases, and someone comes to you with symptoms. Your intuition automatically tells whether it's a myocardial infarction or a GERD, gastroesophageal reflux disease. AI will never know that. The point is, you will know that because of experience. But what AI can do is, it can process 100 million images or 100 million data points in the same breath and tell you these are the reasons why I think it's an MI or it's a GERD. And then you apply your clinical context and say, yes, I agree with the AI. So this is important because more and more as we are progressing, we are in 2026 April, FDA is tightening. Building a model and deploying is not what they're accepting anymore. They're saying, let's see the life cycle of that. But that's a separate topic by itself. This is the essence of explainable AI. It sits on top of black box model and tells you the top three, five reasons why it has been predicted, classified, or described as a particular condition. Now, this is an example, one insight that you can, I'll pause here because this is a real life example. Explainable is not necessarily equal to truthful. For instance, a patient has septic because CRP is high, but almost all the audience in the group knows CRP is also elevated in trauma, cancer, and autoimmune disease and remaining things that are mentioned. So the point from this whole thing, and this happened in real life in sepsis prediction, and there's also good side to sepsis prediction, where it was predicted 6 hours before and saved few lives. But these are the examples where you should apply your judgment and discretion. Good explanation is not necessarily equal to correct medicine. Sound logical reasoning is not equal to being clinically right. You should always validate it and ask a fundamental question. That's the third point on the right hand side. Ask a fundamental question. What is the data that has gone in? And if the data itself is skewed, then you have to take it with that pinch of salt. Erroneous AI predictions can happen for multiple reasons: bias, wrong data, data drift, things like that. Like I said, AI uses correlations, you provide the context. And the fundamental rule right from 1970s, 80s is correlations are not necessarily equal to causations. So, I'll just pause for 2 seconds and then I'll move to the next slide. We have some ground to cover, so don't think I'm rushing. I'm happy to come back to any slide in the Q&A session. So it's not about the sophistication of the model. This is the insight 3 I want to drop. This is about the risk level. The three questions. What if AI is wrong? What is my consequence? What if AI is right and I take a decision? What is my consequence? What if AI is right and I don't act on it? What is the consequence? That determines your risk level. So the medium risk ENT sinusitis screening, it was trained on 1 million plus fundus images, and in that particular case, black box is okay. You can go with black box and rely on that decision. And in high risk ICU sepsis prediction, explainability is required. And there is a real life case study where a sepsis alert was given saying that this person will have sepsis, but the doctor said no, he just underwent a surgery, so the parameters will be high, and they did not do anything like putting him on broad spectrum antibiotics or anything. And in 5 days, he was discharged healthy and no complications. If they have blindly gone with AI prediction of sepsis, they would have given prescribed broad spectrum antibiotics and made him antibiotic resistant in the ICU. So that's where explainability is preferred. Anesthesia dose change. This is absolutely non-negotiable. It must be explainable and it must be justifiable. So the question there is a low to critical risk, the whole spectrum. You need to take a call on where your model, where your decision making is hinging upon. This is actually a clinical example. In one of the deployments, AI suggested reduce propofol dose by 30%. The question is why? And based on what? And if the person is cachectic, which is muscle decay due to disease or age or whatever, then what are the alternatives? This is the whole cycle of decision making that has happened. And where explainability becomes extremely critical, where you cannot trust anyone that says, especially vendors or someone saying we have an AI model. The three questions to ask is, boss, on what population that has been tested on? Is my patient population, demographics and psychographics covered? Habits are covered. So those are the questions that you need to ask. And in these high risk kind of a scenarios, because my understanding as a engineer is propofol is a anesthesia dose. It can cause any kind of a complication on a table. I would defer to Dr. Ashwin and Dr. Suresh on this, but this is a live case study where things have been moderated in spite of AI strongly suggesting to reduce the propofol dose. Uh, so this is your one slide where I don't mind pausing on this for anyone attending to take a photograph of this and keep it. I mean, the deck will be shared, obviously. Routine labs interpretation, they're interpretable, well-established clinical rules, no worries about that. ENT image screening, tested, tried, black box plus review, it's a pattern recognition problem where human verifies. ICU sepsis prediction, we've covered that in detail in previous slides. Explainable AI is required. Um but you can't compromise on the accuracy. Black boxes give you accuracy which is 90%, 92%, 95%. So as long as the task is narrow and it is governed by human oversight, um, it is required. You can use black box safely there. Anesthesia dosing, which is explainable AI. Every parameter must be extremely clear to the practitioner. And he should question why is this particular thing being recommended? What are the top three contributing factors? Or why is it saying so? There are some success and failures I'll discuss in next slide or two slides down. Um, and genomic variant. There is a firm that collects vast amounts of genomic data and they have made it public to compare the genomic data with our population, black box plus expert. Now, I would like to pause here. When would you choose what? So we have discussed extensively about glass box, black box, explainable AI. So I would say you would go with top accuracy ceiling, audit trail, and last one, best for. A glass box is obviously best for end of life consent. Black box models are best for imaging and screening, where we deal with large amounts of CT, MRI scans, and it's humanly impossible. And a fatigue almost sets in. As soon as the fatigue sets in, there is a room for human error to happen. And explainable AI in ICU and high risk diagnosis. So I would be happy to take questions on these things. The like I mentioned, risk level determines the depth of explanation you should seek. It's not about you must or something. You should seek. Routine potassium flag, verify and correct. Black box is acceptable. Maximum, what will happen? You'll order for a retest to ensure that your results are fine. The second one is medium risk. ENT scientist review plus black box is okay there. High risk, sepsis prediction. XAI strongly preferred. Mm, I explained this case study earlier, which happened in real life. Reducing anesthesia propofol by 30% must explain and justify every physiological parameter of the patient. Blind trust may lead to severe consequences that are not acceptable in a clinical setting. So when to use what? I'll just flip on to the previous slide. This is how you choose the right mode. This is how you classify your risk, and then risk level determines the depth of explanation. And of course, all these are overridden by something called audit and traceability. I'll explain in 2 sentences what they mean. Is the model auditable for the decision you're making? Second, if they trace it back to the source and follow the same process, will the result be similar? That is traceability from a AI standpoint. Both of these checks are overriding parameters. So the 3 questions, 60 seconds before you act. What is the risk if AI is wrong? If high consequence, why do I understand why this recommendation was made? Like in our sepsis case or ENT case or ophthalmology case, refer, do not refer kind of a thing. Was this validate? The most important question that we all struggle today. There are abundant data sets to just build a model, and there is no dearth of those models. But all of them are on Western populations, where their physiology is very different from South Asian populations. So validate and check the demographic settings, and specifically ask whether it has been trained on South Asian representation, or do they have enough adequate Indian representation to qualify that model. Uh, this is a case study that I kind of picked up. The explainable AI, one of the techniques that I said is a SHAP. It gave all parameters, uh, and then the post-op response is actually not sepsis. So the doctors, when 5 days before they got an alert, they withheld the antibiotics dose, and the patient was discharged in 5 days without any side effects. And they completely avoided unnecessary antibiotic overdose or help patient developing antibiotic resistance. This is where XAI became in action, and when they probed it further, when the alert came 82% sepsis risk, instead of reacting quickly and putting it on a broad spectrum antibiotics, they questioned it. And this is what came. And they said these are normal post-op inflammatory response, nothing to worry about. Uh, that said, there are 3 real-world evidences, success and failure. IBM Watson is an interesting case study. They spent 700 odd million dollars on saying, okay, the magic of cancer can be observed. But they kind of made a big mistake of taking synthetic data sets, published data sets from universities, and all these data sets are compiled on Western parameters. And the most important thing that happened is African Americans who are underrepresented, because here is an interesting thing that happened. They took cost of healthcare as a proxy parameter for wellness. And typically in US context, African Americans are less represented, so they did not reflect in the cost structure. So they, in general, the model concluded African Americans are happily healthy, which made the entire model fail. There is they had to write off about 700 odd million dollars on this initiative, but it failed. It was even tested in India, according to one report, and it failed very badly. On the other hand, if you look at like left side, um, that successes. Viz.ai is a company that helps prevent a stroke with their diagnosis, and sensitivity is above 90%. But the point is, every time they give an alert and save a stroke, they are saving a tissue in the brain or certain neurons from permanently failing or doing damage. These are real world case studies, and there are more, but I captured the most prominent ones for easier understanding and referenceability. Uh, the validation protocol, obviously, interrogate the training data that I mentioned, external validation. Publishing a white paper by a vendor is not validation. It has to be peer reviewed publication. And please be wary that question the vendor whether it is peer reviewed or not, and validate on your patient. Even if tomorrow, as an AI architect, if I come with a model that says great things about you, I'll show that demo in like 5 minutes if I have the time, and there'll be an open question to all of you on the essence of this presentation. Uh, if you have a ready-made model given to you by someone, test on your 50 to 100 patients of yours before going live. So that answers that first question. Interrogate on the training data. And then who can override the protocol and where it is recorded for the traceback and audit trail. That is extremely important. And then quarterly monitoring. Watch for data drift. No models is stable beyond a certain cadence. It's called cadence in our language. So we determine whether the model is stable for 3, 6, 9, 12, 18 months, and then retrain the model on the new data. So that quarterly was a name that I've used, but it depends on the nature of the data, on when the cadence has to be set for retraining. Uh, I want to show a quick demo and end the session not by thanking all of you, but by asking a question after I show you that demo. Like I said, regulatory guidance is a floor. It's not a ceiling. You have to have this as a floor. So, the DPDP, Data Protection and Privacy Act, SAMD, software as a medical device. I'm sure in other sessions these are covered in detail. Obviously, in EU today, without regulation, you can't enter the healthcare market with a AI product or a tool or a model or anything. And FDA just in 2025 revised their rules that the model, if it is stable in the testing and lab environment, that's not enough. We have to monitor it through the life cycle after deployment. That is a strict thing that came out recently. 5 principles should be explainable. The decision remains with the doctor. Black box is not equal to dangerous. As long as the task is narrow and overridden with human review, there is an application for black box models and they can work. The risk decides the depth. We covered that in detailed slide. And patients need human answers. Even if you have used AI, the answer saying AI said so will not work in real life. You have to explain it yourself. These are the 5 principles to remember. And of course, the NBEMS team and uh, my distinguished colleagues, Dr. Suresh and Dr. Ashwin, already have these things. Uh, I want to quickly show you a demo and a real life case study before I close. But before I open that, Dr. Suresh, do we have time for 2-3 minutes to show that?
We have all the time. But before we jump into the real life demo, I just want to answer a few quick questions and then just hand it over to Dr. Ashwin. The questions which have been repeatedly asked is, if a patient comes with a AI driven recommendation, either from ChatGPT or Claude.
Okay.
Right? So the thing is, and if I as a doctor is wrong, and if AI turns out to be right, then can the patient sue me? The answer is definitely not. Even today,
No.
AI driven answers are not legally acceptable. Okay. The same question. If the AI cannot be sued for its mistakes, it cannot be praised for its good doings also.
Yeah.
Right. So there are enough case laws which have been built across the globe. In India also, we are just having that. So be rest assured, if AI tells something, as long as your decision is backed up by globally accepted guidelines like a endocrine society or a National Cancer Comprehensive Network or APA guidelines or CDC guidelines for the infectious diseases, you are great. Okay, so don't worry about what AI tells. So current legal system tells.
There is a small caveat I would like to add, just one sentence caveat. Your thinking is bang on target. The only thing that AI, especially all the frontier models like ChatGPT, Claude, or anything that you use, they miss the context of the patient that only a practitioner will have.
Correct.
And as long as the context is missing, the patient is carrying a wrong set of information, which may actually lead a clinician to make mistakes.
Correct.
So, what you said is 100% true. I just added 2 cents contribution to that argument.
Great. So
Okay.
one more question I will just answer. Again, a lot of people are asking. Okay, so government models like ABDM, Ayushman Bharat Digital Mission, and other things. Is the data public? Is AI being used? The answer is absolutely yes. In India, we have beautiful models like Kritrim, which is our Indian LLM, Bhashini, that speaks in Hindi, Bhojpuri, Malayali, anything language, that explains the moment you just upload your lab report or clinical summary, it tells in your dialect and language. We have those things available. We will talk to them after Mr. Srikanth will finish his demo. Srikanth, over to you.
Okay, sir. Again, gentlemen, ladies, all the participants, this is a small AI tool based on deep learning. Now, this is a real life problem faced by heart and lung transplant teams. Now, uh, this is how they receive on their WhatsApp. Uh, the challenge
This is a
is,
dummy data, right?
yeah, obviously,
It's a dummy data.
this
I
is a
just
dummy.
want to give a disclaimer.
Yeah,
Yeah.
this is anonymized dummy data they've given to challenge me.
Right.
Okay, I'll just zoom this and quickly explain so that participants can see the challenge that is involved. And then I have a question to them, they can answer. So, where my cursor is moving, those are called UI artifacts. They have nothing to do with the anatomy. And here in the fine print, there is remote control, there is cursor here, not my cursor, but the cursor on the screen. Now, what heart and lung transplant receives is a mobile recorded video, and they should be on their way because all these are emergency cases, either accident or death on the OT or something. And their biggest challenge, follow this carefully, is to estimate the lung volume and breathing capacity. Estimate the breathing volume and lung capacity. Now, I will just set the quality threshold a little higher so it processes. Uh, the question is, they have lot of artifacts and quality issues. They have a standard model that classifies under the glass box model that we discussed till now, which is a formula that is based on age and height of the person who is the donor. Now, that formula is not working in Indian context because the physiology is extremely different. So, if I just click here, what happens is it has estimated the lung volume. 2.51 liters is the lung volume. The confidence is 99.9. I'm happy as an AI architect, but video quality status, it said unfit because I have set a strong clarification criteria. I've only taken high bar towards video quality. Lung boundaries are clearly defined because if you look at my cursor, this is the only anatomical part. The remaining are remote control, monitor artifacts, and blur and lightning effect and all that stuff. Now, uh, there is an anomaly status that says there is a potential fibrosis, emphysema, high boundary variance. I mean, all of you are medical professionals, you understand these terms. There's no need for me to go into details. And this is the AI explanation. This is a practical use case. Now, my question to the audience, I mean, all n number of audience who are following, is this a glass box model, a black box model, or should I have an XAI layer on top of this? Because it has detected the boundaries, it has isolated the remote control and everything in the below screen, the UI artifacts. It has said poor lighting detected, slight motion blur in recording, monitor bezels. Bezels are these things that we see in our laptops and everything. On-screen UI elements. Okay, now they can upload their ground truth DICOM. If the ground truth gold standard DICOM says that the lung volume is 2.4 liters or 2.6 liters, then I'm away only by 10%, which is acceptable in emergency conditions. But, and this 42%, sorry, I forgot to explain, that's the breathing capacity of the lung. But a doctor can easily tick on these things to say, no, I've observed all these things, and this is the training interface. If I get like 1,000, 10,000 images where doctors classify this as emphysema, cavities, bullae in the data set, the algorithm learns. The big question is, in order for this to be in production and real-time decision-making engine, when they're sitting in an ambulance and running this from their mobile and rushing to a patient to capture the lung, donor's lung into a box, does this fall under glass box, black box, or XAI? Suresh sir, is my question clear?
Absolutely clear, and I'm seeing the answers also here in the box. There are a lot of correct answers, and absolutely, it's great. So, I mean, that's a very interesting question to leave. If they want to test they just want to make their hands dirty, please provide the link in the YouTube chat box so that they will go back and then just read about it.
I have
Dr.
no
Ashwin.
problem. All that they need to do is do a screen recording and upload and check it on the ground truth. But I'm not claiming the accuracy because that becomes a regulatory sticky.
No, I understand that.
matter.
Absolutely
Yeah.
understand. Dr.
Yeah.
Ashwin, over to you. I mean, there are a lot of other questions which I missed.
Ashwin sir, back to you. I'm passing the ball, and for time being, I'll go on mute.
Thank you, Mr. Srikanth, for a wonderfully explained session, and I really like the demo part of it. So let me pick up few questions because I think we have another hardly 3-4 minutes left. So one interesting question I've noticed is it malpractice to ignore black box device because it does not give the reasoning? So here, let me answer this question actually. So black box devices generally are used for complex pattern recognitions. Like say if you take waveform recognition in an ECG or radiology images. And these take a lot of inputs as the speaker explained earlier. So usually they have a high degree of accuracy. So it's not straightforward malpractice to ignore the black box advice. But if there is a clinically relevant warning, it might lead to a medical legal risk. Anything to add, Dr. Suresh or Mr. Srikanth?
No, that's perfect, sir. Please go ahead. Have you, see, Dr. Ashwin, have you used anything in your practice?
So yes, we did use, we are using many of them. So because we focus on last mile care, we particularly focus on screening monitoring, decision support, and other operations. So in case of the screening thing, we are using an image analysis tool, which analyzes the cervical images for cancer detection, cervical cancer detection. And this is a black box model we are using. But however, we are developing layers where it can explain which part of the region is abnormal, what is the confidence level and all, to make it an explainable layer. So in the monitoring side of it, we are using in the command center early warning system. On the decision support, we have a recent innovation called Dr. Anna, which is a clinical assistant. Here, apart from transcribing the doctor-patient conversation, what it does is it also gives the differential diagnosis and the drug-to-drug alerts. And this is particularly useful because this is based on a rule book, and this is an explainable AI model there. And RAC IQ is a pharmacy inventory management system. It is purely an explainable AI model. It used for stock counts, expiry dates, and other things. So we have implemented a lot of them. So we have black box models, we have explainable AI models in our system. And probably we would like to add more in the future. So do we still have for some more questions? I would like to take.
So before we go, Srikanth, the chat box is filled up with a lot of curiosity and what is the right model that you
What
are
is the right answer?
Is it black box or explainable AI? As a examiner, you are supposed to give the right answer also. Please, Srikanth sir, what is the model that you have built upon? What you have shown on the lung volume?
I left it as a question to the participants, but since you probed it and Dr. Ashwin also probed it, I'll answer. Okay, there are two answers to it. One, it is based on deep learning and it's a black box model and it's accurate in boundary detection and lung volume estimation. Okay. Now, the second one, if it has to predict the emphysema or bullae cavities or any tuberculosis, especially in heavy smokers, it requires a large volume of data to be trained on. Then it becomes an XAI model.
Great.
But it's not a glass box.
Got it. It's a black box with the added layer of the
XAI.
explainable. Wonderful. Ashwin, please go ahead with the questions.
Okay, so the next question is explainable AI model more expensive than other models?
Srikanth, yourself.
Actually, there is nothing like more expensive because in the discipline of building the model, if either shapely explanative decisions or lime are built in, then it becomes part of the process of model building. So it's not a separate expense. It's part of the discipline that is required in building a model.
Does it cost more
Especially,
in terms of
just
design
a
or
last small
validation?
point, especially in certain sectors like healthcare and banking and all, where there is a requirement for auditability and traceback, this should be part of model building exercise, not an afterthought.
So let me take the next question. So how are these three models coded and trained, and how are they validated?
Okay, Glassbox, for instance, is a straightforward formula. MELD, anybody can look up, they'll get a formula with weightages, creatinine, the EGFR and stuff like that. So that need not be explained. It's being used from last 20, 30 years. I think Dr. Kim has pioneered that MELD model. Anyway, for Blackbox, the choice is between narrow task and large volumes of data to be processed. And XAI is a layer on top of a black box to explain what are the three contributing features. Is age, gender, smoking, past surgeries, those examples, are they causing any, this particular prediction or classification? So, to answer your question up to the point, there is no choice of one or the other model. In my personal language, it's horses for the courses. You determine the task that you want to achieve and the model automatically falls in place.
Great. So we are clocking at 5 o'clock. We have a hard stop. Thank you very much. You have the mail details of both speaker and moderator. We can always reach out to them, and NBMS, we are there. Thank you, Mr. Srikanth, for a wonderful lecture, and Dr. Ashwin for sharing your real life thoughts.
Thank you, sir. Appreciate.
you.
Thank you for the opportunity.
Over to you, NBMS, for any final comments.
I would like to make one final comment.
Please go ahead.
As the speaker said, AI does not replace doctors, but doctors who understand AI can replace the doctors who keep fighting with
We
it.
ignore it. Yeah,
Who
you
ignore
got
it.
it
Keep
right.
fighting
Thank
with it.
God.
Great. So
Yeah,
thank
so
you very
let's-
much. NBMS, we can just wind up the session now. Thank you.
Thank you, sir.
Thank you, Dr. Srikanth, sir. Thank you, Dr. Ashwin, sir, and thank you, Dr. Suresh, sir, for the wonderful session. Thank you, all of you. Thank you so much.
Thank you.
Thank you.